In this section now we will talk about the complications of suppurative otitis media, and specifically we will talk about the intracranial complications of suppurative otitis media. In this section, we will talk about the clinical features and treatment of intracranial complications, subdural abscess, and then we will talk about the otitic hydrocephalus. Intracranial complications of otitis media. Extradural abscess. Extra means outside. Dura is the meninges that covers the brain and the spinal cord. So extradural abscess. Collection of pus between the bone and the dura. So it's the collection of pus between the bone and the dura. So extradural abscess. Bone over the dura is destroyed by hyperemic decalcification. So hyperemic decalcification leads to erosion of the bone over the dura. Spread of infection can occur by venous thrombophlebitis. So from this infection occur, or the infection reaches the extradural area as a result of venous thrombophlebitis from suppurative otitis media, when the thrombus is formed in venous circulation, and when this reaches the extradural area, it can cause their extradural abscess. So the spread of infection is by venous thrombophlebitis. Extradural abscess is formed. Next, clinical feature of extradural abscess. In this diagram, you can see there is collection of pus between the bone and dura, occur in acute and chronic infection of the middle ear. So it can, as a result of thrombophlebitis, it can cause extradural abscess. This is the dura, and then this is the extradural abscess side. So dura and extradural. Clinical feature, there is persistent headache on the side of otitis media. So persistent headache, if this right ear is involved, or if there is otitis media of the right side, then there is headache mostly on the right side. So headache on the side of otitis media. Pain in the ear is common. General malaise with low-grade fever is present. Pulsatile, purulent ear discharge. Pulsatile, it's pulsating and there is discharge from the ear. Disappearance of headache with free flow of pus from ear. So when the abscess or spontaneous drainage of abscess occur, then the headache is disappeared. Treatment is cortical or modified radical or radical mastoidectomy, often required to deal with causative disease process. So whatever is the causative disease, mastoidectomy is performed, radical mastoidectomy. This is the cortical mastoidectomy, hair removal, digastric ridge, lateral semicircular canal, sinus plate, dural or tegment plate, posterior canal wall. So all this is involved cortical mastoidectomy. Antibiotic cover is given to treat the abscess. Next is the subdural abscess. Subdural is collection of pus between dura and arachnoid. So subdural is between dura matter and arachnoid matter, and these are the two meninges. When the pus is formed in between the two meninges, dura mater and arachnoid matter, this abscess is known as the subdural abscess. Infection spread from ear by erosion of bone and dura or by thrombophlebitic process, in which case intervening bone remains intact. So in this state, as we mentioned, in extradural, it's between the bone and the dura mater. So in that case, the bone was eroded, but in this case, the bone is preserved or it's not affected, and it's the infection spread from the ear by erosion of bone and dura mater or by thrombophlebitic process. Clinical features are: symptoms of subdural abscess are due to irritation of meninges, arachnoid and dura. Both meninges are affected. Infection of those meninges lead to meningitis, and meningeal irritation leads to headaches, neck rigidity, fever. All these complications can occur. Cavernous cortical venous thrombophlebitis. So symptoms, whatever symptoms are, it can be due to meningitis and thrombophlebitis. Raised intracranial tensions are present because its abscess and pressures are raised. In this diagram, you can see these are the burr holes: parietal burr hole, then we have frontal burr hole, temporal burr hole, middle meningeal artery. These are the burr holes to drain the abscess. Treatment is a series of burr holes, or craniotomy is done to drain subdural empyema. So when the pus is present, to drain that abscess, the burr holes are done in the different areas of the skull. So these are the holes in the frontal area, then in the parietal, and in the temporal region. Intravenous antibiotics are also given. Then otogenic brain abscess. These are the diagrams that shows these brain abscesses. Route of infection is middle ear infection through tegmen or by retrograde thrombophlebitis, or by direct extension through Trotman triangle, or by retrograde thrombophlebitis. So all these are the route of infection for developing otogenic brain abscess. These are the abscesses present autogenic. Bacteriology of autogenic brain abscess. Aerobic are the organisms that require oxygen for their growth and multiplication. Include Streptococcus pneumoniae, Streptococcus hemolyticus, Proteus mirabilis, E. coli, and Pseudomonas aeruginosa. Anaerobic are Peptostreptococcus and Bacteroides fragilis. So these are the bacteria that can cause autogenic brain abscess. Pathology of autogenic brain abscess. First initial stage of invasion, that's initial encephalitis. Stage of localization, in this there is latent abscess. Stage of enlargement, manifest abscess. Clinical features due to raised intracranial tension, disturbance of function in the cerebrum or cerebellum. And then there is rupture of the abscess. So this pathology of autogenic abscess is in 4 stages. First stage, when there is invasion, leads to encephalitis. or involvement infection of the brain tissue. Then there is abscess formation, and then there is enlargement of this abscess leads to pressure in the increase in the pressure or increase intracranial tension and cause disturbance in the function of cerebrum and cerebellum. And then in the final stage or stage of termination, there is rupture of abscess. Clinical features is extradural abscess, perisinus abscess, meningitis, sinus thrombosis and labyrinthitis. Localizing features are temporal abscess, including normal aphasia, homonymous hemianopia, contralateral motor paralysis, epileptic fits, pupillary changes and oculomotor palsy. Then cerebellar abscess leads to headache, spontaneous nystagmus, ipsilateral hypotonia and weakness, ipsilateral ataxia, and post-pointing and intention tremors. All these are the clinical features and complications of depending on whether it's temporal lobe or cerebellar abscess. If it's temporal lobe, there is nominal aphasia, difficulty in speech, homonymous hemianopia, vision problems, contralateral motor paralysis, weakness of the muscles on the opposite side, epilepsis, pupillary changes. When it's involvement of the cerebellum, cerebellum is mainly involved with the movements. There is headaches, nystagmus, hypotone. Ipsilateral means on the same side there is weakness and less loss of tone. There is same side ataxia, movement problems, and there is past pointing and intention tremors present. So all these are the clinical features of depending on temporal lobe, autogenic abscess or cerebellar abscess. Dysdiadokinesia. Investigation, CT scan, and then CT scan showing left cerebellar abscess. And then we have the CT scan of right-sided autogenic cerebral abscess. This is the cerebrum abscess. This is the cerebellar abscess, depending on which areas are involved. So skull X-rays, CT scan, X-ray of the mastoid or CT scan. Lumbar puncture is to rule out the any hemorrhages and what if there is any other to remove the cerebrospinal fluid to find out the causative agent also. Treatment is radical mastoidectomy is done for surgery, and medical is antibiotics, chloramphenicol, and third generation cephalosporins are given, dexamethasone. And then neurosurgical is repeated aspiration through a burr hole is done, excision of abscess, open incision of abscess, and evacuation of pus. Autologic radical mastoidectomy is done. Then the otitic hydrocephalus. Otitic hydrocephalus is raised intracranial pressure with normal CSF finding seen in children and adolescents with acute or chronic middle ear infection. So otitic hydrocephalus, increased pressure with normal cerebrospinal fluid. So fluid, that's why the term both otitic is for ear, hydro is fluid or water in the brain. So when this occur in presence of normal cerebrospinal fluid associated with otitis media, the term otitic hydrocephalus is used. Mechanism: lateral sinus thrombosis accompanying middle ear infection as a result of obstruction to venous return. So thrombosis can cause this complication or otitic hydrocephalus as a result of obstruction to venous return. Otitic hydrocephalus signs and symptoms: severe headache, diplopia or double vision. Why this occur? As a result of paralysis of cranial nerve. And then we have blurring of vision, papilledema, nystagmus, lumbar puncture is done. Treatment is acetazolamide and corticosteroids, lumbar puncture or placement of lumbar drain, and antibiotic therapy. So otitic hydrocephalus, mostly if you see, it affects the vision as a result of increased pressure. So papilledema, nystagmus, blurring of vision, double vision, headaches. And then this is the diagram. You can see this is otitic hydrocephalus here. So increase fluid otitic hydrocephalus in the brain. So that was all about the section 4, in which we talked about the intracranial complications, and then we talked about the extradural abscess, subdural abscesses, orthogenic abscesses, and their complications and how they can be managed and treated. Thank you for watching sqadia.com.